My name is Dushimirimana Theophile. I'm a licensed clinical officer. I'm here to present about hypertensive disorders of pregnancy. This is a clinical part that I'm going to present. My colleague Nathan has presented about introduction. We are going to go through this clinical part of eclampsia and preeclampsia. Hypertensive disorders of pregnancy, it has two parts. There is hypertension, pregnancy-induced hypertension and chronic hypertension. This means that 6 to 80% of pregnant women do have these hypertensive disorders of pregnancy. Chronic hypertension is seen or diagnosed before 20 weeks of gestation, and pregnancy-induced hypertension is seen above those 20 weeks of gestation. Pregnancy-induced hypertension is also broken into two parts, which is pregnancy-induced hypertension without proteinuria and preeclampsia. The preeclampsia has proteinuria plus or minus, with or without edema. Preeclampsia also has three parts which can be complications of preeclampsia. There is preeclampsia with severe features, eclampsia and Herp syndrome. Those are like complications of preeclampsia in pregnancy. We have also classification of preeclampsia, which is classified into two categories. There is chronic hypertension, as we have seen it in this flow chart. There is chronic hypertension and gestational hypertension, which is pregnancy-induced hypertension. Also, there is preeclampsia, which is superimposed on chronic hypertension. By definition, preeclampsia, there is no definitive cause of preeclampsia. This preeclampsia is defined by criteria, which is hypertension with proteinuria on pregnancy, which is below, greater than 20 weeks of amenorrhea. It means we say that the patient has preeclampsia when she has hypertension and proteinuria in the gestational age of greater than 20 weeks. The hypertension is diagnosed when systolic blood pressure is greater than 140 millimeters of mercury and the diastolic blood pressure of 90 millimeters of mercury on two measurements just 4 to 6 hours apart. It means we wanted to rule out any other causes of that increase in blood pressure. When you have hypertension with proteinuria, we say that there is a proteinuria when proteins present in urine is greater or equal 300 milligram per 24 hours. It's per day of corrected urine. This preeclampsia is only cured by delivery. It means when a pregnant woman presents with this eclampsia, after delivery, it's the time where we say there is a cure of this disease. Eclampsia also occurs, occurrence of this eclampsia happen when there is preeclampsia with tonico-clonic seizures. It means the mother can present to the clinic with hypertension, high blood pressure, with proteinuria or edema, and after having that, she may present also with tonico-clonic seizures. That's when we say this patient has eclampsia. The occurrence of seizures or tonico-clonic seizures have been revealed that they occurs in 28% of antenatal cases. Intrapartum, it means during the delivery, it accounts for 18%. Postnatal, it is account for 44% within 48 hours. It means eclampsia is not only diagnosed antenatally, it also continues even postpartum within 48 hours. Going through epidemiology of preeclampsia, eclampsia occurs in approximately 5 to 6% of all pregnancies, but in 10% of first pregnancies and in 20 to 25% of women with chronic hypertension. The study also revealed that 10% of preeclampsia occurs in pregnancies of less than 34 weeks of gestation, where eclampsia is estimated to occur in 1 out of 200 cases of preeclampsia, if no prophylactic magnesium sulfate given to that client. It means if you receive a patient as a clinical officer or any other healthcare provider at a health facility, if you receive a patient with right upper quadrant pain, epigastric pain, or nausea and vomiting in the 3rd trimester, the client should be immediately referred throughout that Herp syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. It means thrombocytopenia. We are also going through the risk factors that predispose these clients to this disease, which is preeclampsia or eclampsia or Herp syndrome. Among those risk factors, there are moderate risk factors and high risk factors. Moderate risk factors, preeclampsia occurs in first pregnancy, just prima gravida, and in people who are aged greater or equal to 40 years old, pregnancy interval of greater than 10 years, family history of preeclampsia, multiple pregnancies. Those are moderate risk factors, as you can see in this presentation. Where high risk pregnancies, there is hypertensive disease during previous pregnancy. It means during history taking, you have to make sure that the client does have the prior history of hypertension or not. Also, there is chronic kidney disease, CKD. Those clients with CKD, they are also at risk of having that preeclampsia. Also, there is autoimmune disease like systemic lupus erythematosus, diabetes mellitus, type 1 or type 2, and chronic hypertension. So there is a study conducted by American College of Gynecology and Obstetrics that was carried out in 2020 that revealed that if it recommends that it's better to give aspirin, low dose aspirin in clients with this hypertension to prevent the preeclampsia during this pregnancy. The criteria to give this prophylaxis is you have to make sure that the client has 2 or more moderate risk factors to give that high dose of aspirin. And if the client has 1 high risk factor, you can give that prophylactic aspirin for 12 weeks until birth. But in our country, there is other guidelines that are used in clinical practices that we should not go beyond. Also, we know that non-steroidal anti-inflammatories are contraindicated during pregnancy due to the increased risk of development of PDA, patent ductus arteriosus, in children. These risk factors also have been revealed. The one we didn't talk about is about family history, where there is a family relative of the parturient. It means family relative of the pregnant woman. When there is preeclampsia or eclampsia among her relatives, there is also a risk of getting that preeclampsia or eclampsia. Also, when the mother-in-law of the pregnant woman, if she had that preeclampsia, also that woman has a risk of developing eclampsia. Also, the study revealed that cohabitation in less than 1 year increases the risk of having preeclampsia. This is to say that, for example, if a woman has married the first husband and later on he marry another man, if she conceives in less than 1 year, there is a risk of developing that preeclampsia. Going through pathophysiology, there is no known mechanism yet leading to that preeclampsia, but there is some factors that contribute to the development of that disease. There is an abnormal placenta development, and these risk factors are broken into two parts. There is maternal and fetal factors. An abnormal placenta development and maternal endothelial dysfunction has led to placental hypoperfusion. It means when the placenta is developed abnormally and maternal endothelial dysfunction will lead to placental hypoperfusion. The placental hypoperfusion will lead to secretion of vasoactive substances as a response to that placental hypoperfusion. Those vasoactive substances are circulating anti-angiogenic factors, and those vasoactive substances will lead to endothelial region, which is responsible for clinical manifestations and also lead to increased vascular permeability. Due to that, there is a generalized vasoconstriction of the mother or pregnant woman that will lead to increased risk of hypertension. Also, increased vascular permeability will lead to development of edema and proteinuria. The increased vascular constriction leading to hypertension. The hypertension also will cause breakdown in cerebral autoregulation, leading to overdistension of vessels and extravasation of fluids, then resulting into development of edema that can be observed on the feet, hands, and the face. Also, it may complicate into pulmonary edema. There is also fetal complications that happens during preeclampsia. Those are caused by prematurity, because when there is a preeclampsia with severe features, we have seen that the cure will be delivery, when even the baby can be delivered prematurely. And other complications will be related to that prematurity. As we have said, generalized vasoconstrictions lead to uteroplacental insufficiency due to hypoperfusion. That blood pressure, high blood pressure related to generalized vasoconstrictions will lead to also complications known as abdominal placenta or fetal hypoxia, and when it becomes chronic, it will lead to intrauterine growth restriction. Maternal generalized arterial vasoconstrictions also affect the brain. When it affects the brain, it's where the mother will come with seizures. Kidneys, where there will be low EGFR, it means creatinine clearance will be down. It will also affect the lungs, where the mother will develop pulmonary edema. The liver and small blood vessels. When the liver is affected, the mother will develop edema and hematoma, which is subcapsular hematoma of the liver. That's why the client will develop some signs and symptoms like she may come complaining of light upper quadrant pain and epigastric pain, and by physical examination we can find that there is tenderness in right upper quadrant and epigastric pain. That is where we have to immediately refer the client to the higher facility when we are in low resource setting. When the blood vessels are, small blood vessels are affected, there will be hemolysis and also thrombocytopenia that can happen as complication of high blood pressure during pregnancy. Going through what we can do at our health facility, there is also history taking. During history taking, the clinician or clinical officer or any other healthcare provider should know about symptoms. It means what brought the client to the clinic or chief complaint. You have to ask about there is a headache as a symptom, especially it is a frontal headache. Visual disturbances, especially the client will complain of flashing lights, and she may complain of epigastric or right upper quadrant pain, nausea and vomiting, rapid edema, especially facial edema. It can be also called moon face. Symptoms usually only occur with severe diseases. It means these symptoms does not occur always in minor features of this preeclampsia or eclampsia. It occurs with preeclampsia with severe features. Examination. This is the physical exam. The clinician should take blood pressure of the pregnant woman, where when she has this preeclampsia, blood pressure will be 140 out of 90 millimeters of mercury, or 160 out of 110 millimeters of mercury if it is severe. It means blood pressure of greater than 140 out of 90 millimeters of mercury it's not severe. When the client has that high blood pressure and proteinuria, it means proteins which are greater than 300 milligram in 24 hours, we say that the client has preeclampsia. Then she may have also facial edema, epigastric and right upper quadrant tenderness just on palpation. Then if she has epigastric or right upper quadrant tenderness on palpation, it means there is liver involvement and capsular capsule distension. This capsule is a part of the liver. When you palpate the client, she will feel pain. There is also hyperreflexia plus with or without clonus. This means there is cerebral irritability. It means there is an effect of that high blood pressure to the brain. There is uterine tenderness or vaginal bleeding from placental ablation. There is also fetal growth restriction, retardation on abdominal ultrasound, especially if the baby is less than 36 weeks. We are also going through classification and the clinical manifestations of preeclampsia and preeclampsia. Preeclampsia without severe features is classified by taking blood pressure, where systolic blood pressure is 140 millimeters of mercury, and also it means from 140 millimeters of mercury to 159 millimeters of mercury. The systolic blood pressure will be 90 millimeters of mercury to 109 millimeters of mercury. This means that the client has high blood pressure plus sudden swelling of the face, hands or feet, and proteinuria on random urine dipstick, or at least 300 milligram to 500 milligram of proteins in 24 hours urine correction. We will say that the client has preeclampsia without severe features when she has high blood pressure not going beyond 159 millimeters of mercury, systolic blood pressure, and diastolic blood pressure going not higher than 109, plus facial swelling on random urine and the proteinuria on random urine, and proteinuria of between 300 milligram and 500 milligram in 24 hours of urine correction. So the diagnostic criteria for preeclampsia with severe features, you will have those features of preeclampsia without severe features plus or with headaches, visual disturbances, pulmonary edema, hepatic dysfunction, right upper quadrant or epigastric pain, or iguria, elevated creatinine, proteinuria. If you have one or two of these symptoms or signs plus preeclampsia without severe features, that will lead to diagnosis of preeclampsia with severe features. And plus there is systolic blood pressure of greater than 160 to 180 millimeters of mercury, and diastolic blood pressure of greater than 110 millimeters of mercury, and the proteinuria or hemolysis, thrombocytopenia of less than 100,000, also plus those features of preeclampsia without severe features will lead to preeclampsia with severe features. It means these signs and symptoms plus features of preeclampsia without features, severe features will lead to severe preeclampsia. So severe preeclampsia with tonico-clonic seizures resulting to eclampsia. These are some complications of eclampsia to the mother. Eclampsia can lead to heart failure, eclampsia, cerebrovascular accident, placenta abruption, renal failure, Herp syndrome, and postpartum hemorrhage. These are some complications, but it does not happen to all women, but it may happen. It depends on the severity of preeclampsia. There is also complications of fetus. There is a fetal growth retardation, fetal distress, fetal death, and also neonatal asphyxia. All of these can happen, or one can happen. It depends on the intervention. When it is timely intervened to help this mother, the fetus can not have some of these complications. We are going through the management of preeclampsia. The objective of this management is just to cure and prevent progression to the severity of this disease by close monitoring of the client. The aim is to reduce the blood pressure. Our target should be 140 out of 90 millimeters of mercury, and also to promote fetal maturity, as we will see in the following slides, to prolong pregnancy at least between 34 to 36 weeks, and this is the aim of prolonging pregnancy, is to achieve the fetal maturity and prevent pregnancy termination. Also, the aim is to deliver and prevent also and manage complications which can be postpartum or intrapartum. We have also laboratory investigation that should be done. We have to do full blood count, proteinuria, urea and creatinine, liver function tests, electrolytes and uric acid. We have to do this full blood count to see the level of platelets, so that we can see if there is thrombocytopenia. Proteinuria to see whether there is protein in urine, which can be greater than 1 or greater than 300, greater or equal to 300 milligram per 24 hours of urine collection. Also, we have to see whether there is kidney involvement or kidney damage by taking urea and creatinine. Liver function test to see the liver involvement and electrolytes. Also uric acid to prevent or to intervene for uremic syndrome that can develop later as complication of this preeclampsia. Also, we have to do imaging, just chest X-ray in case of there is dyspnea. During chest X-ray, you can see also if the client has developed the pulmonary edema on chest X-ray. You can do also brain CT scan to exclude hemorrhage, as we have seen that some of complications of preeclampsia can be CVA, cerebrovascular accident. You can also do obstetrical ultrasound to see or to monitor the fetus to see if there is intrauterine growth retardation. Continuing to management, preeclampsia without severe features, after 37 weeks of pregnancy, we have to deliver the baby. If it's prior to 37 weeks, we do expectant management. And if it's greater than 34 weeks with premature rupture of membrane, intrauterine growth restriction, preterm labor, in this case, delivery is recommended. Also, we have to give corticosteroids for fetal lung maturity when there is gestational age is less than 34 weeks. This is because if the mother delivered a baby which is less than 34 weeks, there is a risk of lung collapse due to lung immaturity. There is no production of surfactant that prevents lung collapse before these 34 weeks. So we have to make sure that we give corticosteroids. In our country, we are using dexamethasone that is used to promote this lung maturity when gestational age is less than 34 weeks. This is the flow chart that is followed in management of preeclampsia with the severe features. When there is maternal deterioration, as we are monitoring this client, or there is severe intrauterine growth restriction, fetal compromise, or she's in labor, when she is greater than 34 weeks of gestation, we have to deliver within 24 hours. So we have to induce labor when there is no other contraindication. If she's less than 34 weeks, or she's not having severe intrauterine growth restriction, retardation, maternal deterioration, or fetal compromise, if they are not there, and the mother has 28 to 34 weeks of gestation, you have to give corticosteroids. We use dexamethasone. In other countries, they use betamethasone. Also, we give antihypertensive drugs, and we evaluate daily the mother and fetal conditions until she reaches 34 weeks of gestation. And if she's 33 to 34 weeks, we have to do amniocentesis to see whether there is fluid maturity or immature. If the fluids is immature, it means the fetal lung maturity is not yet mature. We give corticosteroid to promote fetal lung maturity and deliver the baby within 24 hours after completion of doses of corticosteroids. If there is features of lung maturity, immediately you deliver the baby. Going to eclampsia management, first of all, we have seen that there is preeclampsia with the severe features plus tonico-clonic seizures. That is when we say there is eclampsia. The management is just, you can follow the protocol ABCD, where we protect the airway to minimize aspiration. Also, we have to prevent maternal injury as she has conversion. And also, if you are in the setting where there is magnesium sulfate, it should be immediately given to control those conversions or seizures. We give 4 to 6 milligram loading dose and 1 gram per hour up to 48 hours post-delivery. It means we have seen that this eclampsia can continue in postpartum, 44 hours postpartum in about 44% of cases. So when the client is stable, plan for delivery. It means you cannot deliver the baby when the client is not stable. It means when she's still conversing, you have to wait to control those seizures and make the client stable and then plan for delivery. The management by giving antihypertensive treatments are required when systolic blood pressure is greater or equal to 160 millimeters of mercury and diastolic blood pressure greater or equal to 110 millimeters of mercury. This is an emergency hypertension we should give hydralazine when you are in the setting where there is this medication. This is given IV, intravenous bolus of 5 to 10 milligram, and can be administered every 20 minutes, and the maximum dose should not be greater than 30 milligram. This hydralazine causes direct arterial vasodilation and then improve renal and uteroplacental blood flow. As we have seen that this hypertension is also caused by reduced abnormal placenta development that has led to systemic vasoconstriction. If you give hydralazine, it will reverse the vasoconstriction to vasodilation, then improves renal and uteroplacenta blood flow. We should also give labetalol, which is a non-selective beta blocker, IV every 10 minutes. The initial dose is 20 milligram and second dose 40 milligram. Following dose is 80. It is doubled in every dose that is given. There is also nifedipine that is used for management of hypertension, which is calcium channel blocker. It is given by mouth, 20 milligram every 15 to 30 minutes. The maximum dose is 120 milligram per day. There is also alpha methyl dopa, but it has low onset of action. It is centrally acting antihypertensive drug, which is given as 250 milligram 3 times, and the maximum dose is 2 grams per day. Sodium nitroprusside, it's also given in hypertensive emergencies. It's not being used here in Rwanda. There are also discouraged treatments for hypertension in pregnancies. We should not give angiotensin converting enzymes inhibitors because they are contraindicated in pregnancies, as they can cause intrauterine death, oliguria, renal failure in mother and neonates. Also, we have to avoid diuretics because they can deplete intravascular volume, as the mother can urinate a lot. We have to give anticonvulsants. The indicated anticonvulsant in pregnancy when the client has preeclampsia with severe features or eclampsia, we have to give magnesium sulfate. The patient with severe hypertension or severe preeclampsia and has history of pre-eclamptic seizures, we have to give magnesium sulfate. This is the one which is indicated. If birth is planned within next 24 hours for patients with severe pre-eclampsia, also you have to give that magnesium sulfate. These are the cases where we have to give this magnesium sulfate. It means patient with severe hypertension or severe preeclampsia or has history of eclamptic seizures, and if the birth is planned within 24 hours with severe preeclampsia, we have to give magnesium sulfate. How to give it? We give a loading dose of 4 grams IV over 5 minutes, then infusion of 1 gram per hour over 24 hours. If recurrence of seizures, further dose of 2 to 4 grams is given over 5 minutes, and you have to continue for 24 hours postnatal. Corticosteroid, if are given when the birth is likely to happen within 7 days in a patient with the preeclampsia. Between 24 to 34 weeks, we give 2 doses of betamethasone IV, 12 milligram in 24 hours apart. It means we have to give those 12 milligram within 24 hours. And then we give IV dexamethasone 6 milligram, 4 doses in 48 hours. These corticosteroids are being used to promote fetal lung maturity so that we can prevent fetal lung collapse, as surfactant is not yet produced within this period. But we have seen that we should do amniocentesis when the mother is 33 to 34 weeks of gestation. And if fetal lung maturity is diagnosed within that period, you can deliver the baby. Immediate delivery is done if worsening of thrombocytopenia or coagulopathy, worsening of liver or renal functions, also severe maternal symptoms, especially epigastric pain, fetal distress, or reversed umbilical artery flow, or also Herp syndrome or eclampsia is diagnosed, you have to do immediate delivery after making sure that the mother is above 34 weeks of pregnancy. Fetal monitoring should be done by using CTG. You have to repeat it if there is a change in movement, in fetal movement, also vaginal bleeding and abdominal pain or deterioration in the mother condition. It means if the mother was having preeclampsia with severe features and then she developed seizures or tonico-clonic seizures, you have to monitor also the fetal well-being by monitoring her or his heart rate by using this CTG. Also, you have to manage if she has that severe preeclampsia or eclampsia by giving magnesium sulfate. You have also to do the follow-up to rule out any sign of postpartum eclampsia, close monitoring of urine output to control platelets or liver function tests and renal functions. Also monitor blood pressure as well as postpartum period. These are the follow-up we have to do for the mother with this severe preeclampsia or eclampsia. Herp syndrome is coming as a complication of preeclampsia. This was named like this by Weinstein, who regarded signs and symptoms to constitute an entity separate from severe preeclampsia in 1982. He named this as Herp, which means there is hemolysis. H stands for hemolysis. ER stands for elevated liver enzymes. LP stands for low platelets. Currently is regarded as a variant of severe preeclampsia or a complication of that preeclampsia. This syndrome occurs in 0.5 to 0.9% of all pregnancies, 10 to 20% of cases with the severe preeclampsia. Also, they are at risk of developing this Herp syndrome. 70% of the cases develops before delivery with a peak frequency between 27 and 37 weeks of gestation. 10% occurs before 27 weeks. The symptoms of this Herp syndrome is right upper quadrant pain, epigastric pain, nausea and vomiting, where 30 to 60% of women have headache and 20% have visual symptoms like seeing flashing lights as a symptom. By physical examination, you can palpate the client and you will feel, she will feel pain or tenderness in the right upper quadrant and epigastric region. If you do that, when the client did not complain of that, and when you do this and she feels pain, make sure that the client is at risk of developing that Herp syndrome. When you are in the setting where you cannot manage this client, make sure that you do immediate transfer to the higher or advanced facility. Laboratory findings in Herp syndrome, there is hemolysis due to, you will find it in abnormal peripheral smear, total bilirubin which is greater than 1.2, lactate dehydrogenase which is greater than 600 international unity per liter, liver enzymes AST greater than 70, platelet counts will be less than 100,000. These laboratory findings are used to classify the severity of this disease. Classification is based on platelet counts and liver functions, and also hematological findings. Class 1, there is platelet count which is less than 50,000, and class 2 platelet will be between 50 and 100,000, and class 3 platelet counts will be between 100,000 and 150,000. There is also classifications based on whether this Herp is complete or partial. Complete is classified when there is microangiopathic hemolytic anemia in women with severe preeclampsia, and lactate dehydrogenase is greater or equal to 600, and AST greater or equal to 70, with thrombocytopenia less than 100,000. Then, if there is one or two of these features of complete Herp syndrome, it means we say there is partial Herp syndrome. The differential diagnosis of the clients with the preeclampsia, it means there are many diagnoses that can be made based on the findings or complaint of the client. It can be viral hepatitis, as the client may complain of the right upper quadrant pain or epigastric pain, and you can palpate also, she can feel pain or tenderness. You will find that the client may have also viral hepatitis. So throughout them, we have to do also the test of viral hepatitis, cholangitis, and other acute disease of the liver, immunothrombocytopenia. It can be also acute fatty liver of pregnancy, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, also systemic lupus erythematosus. Also, it can be one of differential diagnosis, but it's better to start with features by relating them with pregnancy, so that you can sort what to start with first and then rule out this later. Complications reported in Herp syndrome are given in this slide, as preeclampsia accounting for 9%, abruptio placenta, DIC. DIC means disseminated intravascular coagulopathy. It has 56%, which scores high. It means after delivery you have to make sure that you monitor the client for DIC and also acute renal failure, severe ascites, cerebral edema, and pulmonary edema. These are complications of Herp syndrome based on the findings of the study done in this client's group. Complications reported in the Herp syndrome, there are also, these are maternal complications. The one which scores high is also cerebral hemorrhage as a complication of high blood pressure, which can lead to cerebrovascular accident. There is also maternal mortality rate. A stroke accounts for 45%, which is the highest one, and the second is cardiac arrest. Also, some mothers die of this eclampsia and severe preeclampsia. We have also to tackle this by preventing this to happen by giving magnesium sulfate to control seizures and hypertensives, to control high blood pressure, so that our client cannot suffer from this stroke, which cannot be, as complication cannot be reversed, and also cardiac arrest, which can take life of our clients. Complications also goes to fetal and neonatal, where there is 61% of neonates or fetus can have intrauterine growth retardation, and 60% there is neonatal thrombocytopenia. Also, there is RDS, respiratory distress syndrome, which accounts for 40%, and perinatal death accounting for 34%. These are also complications of this Herp syndrome as a result of severe preeclampsia or eclampsia. Management of Herp syndrome is similar to severe preeclampsia. You have to stabilize the mother, evaluate fetus for compromise, and determine optimal timing or route of delivery, and manage blood pressure and fluid status. So all women should receive magnesium sulfate while symptomatic or in labor, so that we can prevent all these complications of preeclampsia. Management of pregnant women with the Herp syndrome also, we have to immediately deliver the baby once we have diagnosed a Herp syndrome. This is, we have seen that it's a complication of severe preeclampsia. If the baby, the mother has greater than 44 weeks of gestation or later, immediately we have to deliver. If there is no reassuring tests of fetus status, it means the mother can report that there is no quickening or fetal movement, and also you can feel that there is fetal heart rate leading to fetal distress. You can also immediately deliver the baby. If there is a presence of severe maternal disease, it means multi-organ dysfunction, DIC, liver infarction or hemorrhage, liver failure or abruptio placenta, you have to deliver immediately the baby. Abruptio placenta present with sometimes with vaginal bleeding or uterine tenderness. So make sure that as a clinical officer or any other healthcare provider has done with all physical examination to make sure that there is nothing remains behind. In 27 to 34 weeks of gestation, we have to deliver the baby within 48 hours, then evaluate and stabilize the client. Steroid treatment for fetal lung maturity will be given in this period. If the client is before 24 weeks of gestation, termination of pregnancy is strongly considered. This is to make sure that we don't lose two people. So before 24 weeks, there is termination of pregnancy. There are new treatments for Herp syndrome, which is the dexamethasone, which is given IV 10 milligram every 12 hours when platelet is less than 100,000, and platelets for active bleeding can be given when there is hemorrhage. It means when there is active bleeding, we give platelets to help in controlling that bleeding. Also, if platelets are less than 20,000, we have also to give platelets. There is plasmapheresis, which has limited success. This is where the plasma is filtered and given to the client, but is not routinely recommended. So we have to give the dexamethasone and platelet if there is active bleeding or platelets are less than the 20,000. After managing the client and she is stable, and if you plan to discharge the client, make sure that you advise about this condition. You advise the client about the risk of recurrence of preeclampsia, eclampsia, Herp syndrome, or preterm delivery. Patient should know the symptoms and that she should consult earlier on next pregnancy. Plus, she can benefit by taking low-dose aspirin. These have been shown, the study conducted by American College of Gynecology and Obstetrics have shown that aspirin, low-dose aspirin, can minimize the risk of preeclampsia. So you have to make sure that you advise the client about the occurrence of this condition and when to consult the healthcare provider on the next pregnancy. So thank you for your kind attention. This is the recommended readings, and you can find more updated researches or studies done and updated new knowledge about preeclampsia and eclampsia. Thank you.